Mechanism of action. CFTRAXONE has bactericidal activity resulting from the inhibition of bacterial cell wall synthesis, ultimately leading to cell death. CFTRAXONE is stable to a broad range of bacterial Sharp S lactobases. Pharmacokinetic properties. The pharmacokinetics of CFTRAXONE are largely determined by its concentration. Dependent binding to plasma albumin. The plasma-free, unbound, fraction of the drug in man is approximately 5% over most of the therapeutic concentration range, increasing to 15% at concentrations of 300 mg/L. Owing to the lower albumin content, the proportion of free CFTRAXONE in interstitial fluid is correspondingly higher than in plasma. Plasma concentrations. Plasma concentrations. Mean peak concentrations after bolus intravenous injection are about 120 mg/L following a 500 mg dose and about 200 mg/L following a 1 gram dose. Mean levels of 250 mg/L are AKEVED after infusion of 2 grams over 30 minutes. Intramuscular injection of 500 mg CFTRAXONE in 1% lidocaine injection BP produces mean peak plasma concentrations of 40-70 mg/L within 1 hour. Bioavailability after intramuscular injection is 100%. Excretion. Excretion. CFTRAXONE is eliminated mainly as unchanged drug, approximately 60% of the dose being excreted in the urine almost exclusively by glomerular filtration and the remainder via the biliary and intestinal tracts. The total plasma clearance is 10-22 ml/min. The renal clearance is 5-12 ml/min. A notable feature of CFTRAXONE is its relatively long plasma elimination half-life of approximately 8 hours, which makes single or once daily dosage of the drug appropriate for most patients. The half-life is not significantly affected by the dose, the route of administration, or by repeated administration. Pharmacokinetics in special clinical situations. Pharmacokinetics in special clinical situations. In the first week of life, 80% of the dose is excreted in the urine. Over the first month, this falls to levels similar to those in the adult. In infants aged less than 8 days, the average elimination half-life is usually 2 to 3 times longer than that of young adults. Cerebrospinal fluid. Cerebrospinal fluid, CFTRAXONE crosses non-inflamed and inflamed meninges, attaining concentrations 4-17% of the simultaneous plasma concentration. Indications: infections. Indications: infections due to sensitive gram-positive and gram-negative bacteria, surgical prophylaxis. Prophylaxis of meningococcal meningitis and Haemophilus influenzae type B disease. Indication: cephalosporin. Indication: cephalosporin hypersensitivity. Neonates less than 41 weeks corrected gestational age. Neonates over 41 weeks corrected gestational age with jaundice, hypoalbuminemia, or acidosis. Concomitant treatment with intravenous calcium, including total parenteral nutrition containing calcium in neonates over 41 weeks corrected gestational age. Risk of precipitation in urine and lungs. Pathology. CFTRAXONE may be administered by deep intramuscular injection, or as a slow intravenous injection, after reconstitution of the solution. The dosage and mode of administration should be determined by the severity of the infection, susceptibility of the causative organism, and the patient's condition. Under most circumstances, a once-daily dose or, in the specified indications, 1 dose will give satisfactory therapeutic results. Diluents containing calcium, for example Ringer's solution or Hartmann's solution, should not be used to reconstitute CFTRAXONE vials or to further dilute a reconstituted vial for IV administration, because a precipitate can form. Precipitation of CFTRAXONE. Calcium can also occur when CFTRAXONE is mixed with calcium-containing solutions in the same IV administration line. Therefore, CFTRAXONE and calcium-containing solutions must not be mixed or administered simultaneously. Interactions. Interactions. Antacids. absorption of chefaclor reduced by antacids antibacterials, possible increased risk of nephrotoxicity when cephalosporins given with aminoglycosides. Anticoagulants. Cephalosporins possibly enhance anticoagulant effect of coumarins probenecid, excretion of cephalosporins reduced by probenecid, increased plasma concentration, teriflunomide, plasma concentration of CFTRAXONE increased by teriflunomide cautions sensitivity to beta-lactam antibacterials, avoids history of immediate hypersensitivity reaction, false positive urinary glucose if tested for reducing substances, and false positive Coombe-Best test, may displace bilirubin from serum albumin, administer over 60 minutes in neonates, treatment longer than 14 days, renal failure, dehydration risk of CFTRAXONE precipitation in gallbladder. Warnings and precautions. The stated dosage should not be exceeded. If lidocaine is used as a solvent, CFTRAXONE solution should only be used for intramuscular injection. As with other cephalosporins, anaphylactic shock cannot be ruled out even if a thorough patient history is taken. Before therapy with CFTRAXONE is instituted, careful inquiry should be made to determine whether the patient has had any previous hypersensitivity reactions to CFTRAXONE, cephalosporins, penicillins, or other beta-lactam drugs. CFTRAXONE is contraindicated in patients who have had a previous hypersensitivity reaction to any cephalosporin. It is also contraindicated in patients who have had a previous immediate and/or any severe hypersensitivity reaction to any penicillin or to any other beta-lactam drug. CFTRAXONE should be given with caution to patients who have had any other type of hypersensitivity reaction to a penicillin or any other beta-lactam drug. Care is required when administering CFTRAXONE to patients who have previously shown hypersensitivity to penicillins or other non-cephalosporin beta-lactam antibiotics, as occasional instances of cross-allergenicity between cephalosporins and these antibiotics have been recorded. Anaphylactic shock requires immediate countermeasures. Safety and effectiveness of CFTRAXONE in neonates, infants and children have been established for the dosages described under dosage and administration. In vivo and in vitro studies have shown that CFTRAXONE, like some other cephalosporins, can displace bilirubin from serum albumin. Clinical data obtained in neonates have confirmed this finding. CFTRAXONE should therefore not be used in neonates, especially prematures, at risk of developing bilirubin encephalopathy. Cases of fatal reactions with calcium, CFTRAXONE precipitates in lungs and kidneys in premature and full-term newborns aged less than 1 month have been described. At least one of them had received CFTRAXONE and calcium at different times and through different intravenous lines. In the available scientific data, there are no reports of confirmed intravascular precipitations in patients, other than newborns, treated with CFTRAXONE and calcium-containing solutions or any other calcium-containing products. In vitro studies demonstrated that newborns have an increased risk of precipitation of CFTRAXONE, calcium compared to other age groups. Pregnancy and breastfeeding. Pregnancy and breastfeeding. Pregnancy. Not known to be harmful. Breastfeeding. Present in milk in low concentration, but appropriate to use. Renal impairment. Reduced dose effect for less than 10 ml/1.73 meters, 2, max. 2 grams daily. Monitor plasma concentration. If both hepatic and severe renal impairment. Hepatic impairment. Reduce dose and monitor plasma concentration. If both hepatic and severe renal impairment. Side effects. Diarrhea, rarely antibiotic, associated colitis. Nausea and vomiting, abdominal discomfort, headache. Allergic reactions including rashes. Pruritus. Urticaria, serum sickness. Like reactions with rashes, fever and arthralgia, and anaphylaxis. Stevens-Johnson syndrome. Toxic epidermal necrolysis reported. Disturbances in liver enzymes. Transient hepatitis and cholestatic jaundice. Other side effects reported include eosinophilia and blood disorders, including thrombocytopenia, leukopenia, agranulocytosis, aplastic anemia and hemolytic anemia. reversible interstitial nephritis, hyperactivity, nervousness, sleep disturbances, hallucinations, confusion, hypertonia, and dizziness. Calcium CEFTRAXONE precipitates in urine, particularly in very young, dehydrated or those who are immobilized or in gallbladder, consider discontinuation if symptomatic. Rarely prolongation of prothrombine time, pancreatitis symptoms of overdose and particular treatment in the case of overdose nausea, vomiting, diarrhea, can occur. CEFTRAXONE concentration cannot be reduced by hemodialysis or peritoneal dialysis.